Junior doctors, resident doctors, have had a basis for a pay claim for a long time. In real terms, their pay has fallen, and at the same time, their costs have risen dramatically. We live in a society which is actually designed to extract people's income from them and redistribute it. That is the way in which late-era neoliberal capitalism works. Can you actually live on this in a reasonable fashion and be able to support yourself and maybe a family? And it's not an unreasonable goal for a doctor to have a family. Why shouldn't they have one? All of these are structural problems which are being dumped on the NHS to solve without the politicians ever asking the question, why are we running an economy which is actually making people sick?
Hello and welcome to another interview from the BMJ. I'm Kamran Abbasi, Editor-in-Chief. In light of the ongoing dispute between the government and resident doctors, as well as winter pressure on the National Health Service in the UK, we thought we'd ask a money expert about whether resident doctors have a credible case on pay, as well as the broader implications for the health service and government health policy. Here to talk through these issues is the economics activist and co-author of the Green New Deal, Richard Murphy. I'm delighted to welcome Richard Murphy to the podcast today. Richard, welcome.
Hello. Thank you for inviting me.
Yeah, good to see you. I wanted to talk to you, and let's dive straight in. In your career as an expert on tax, the economy, I noticed you making some pretty strong statements about the doctor's strike and the state of the NHS. And I wondered, it'd be good to hear your view on the merits of the strike and the merits of the, not the fact that whether doctors should strike or not, but on the merits of the pay claim that doctors have at the moment.
Let me put my cards on the table because I always like to be transparent. You can't campaign for transparency and then not be so. I am married to a retired GP. I have had some interest in this subject for a long time as a consequence. So, look, I do have some understanding of what I'm talking about here. Junior doctors, resident doctors, have had a basis for a pay claim for a long time. In real terms, their pay has fallen, and at the same time, their costs have risen dramatically. I mean, we're talking since 2010 fundamentally, but the costs have risen dramatically because of the burden of student debt, which has risen over that period, which is RPI indexed. We have seen the increase in the cost of living in that period, which has been real and which isn't wholly reflected, I think, in the cost of living indices, whichever one you use, CPI, RPI, because of the increase in house prices. And most doctors will aspire to own their own property. We've seen of late increase in interest rates, which again has not been reflected in the true cost of living, like so much else. And so doctors have suffered what is now called an affordability crisis. However much they're being paid, they can't actually afford to maintain a standard of living, which you can reasonably expect to have after doing 5 years of a degree, 100,000 of student debt, quite possibly, and 2 years at least of postgraduate training, and then after that going into further training courses, which you will partly have to fund yourself. Take all that into account, and the pay that resident doctors are getting from the NHS is in fact pretty poor. Look at other potential outcomes that doctors could rationally take if they were the rational human beings that economists assume exist but don't actually in practice, as we all know. The fact is that there is competition for people with skills, and doctors are frankly not doing very well on the basis of the pay claims they've got, given in addition, and I know a little bit about this, the fact that many doctors go home and don't sleep at night because they're worried about the outcome in the morning. My wife always used to joke about the fact that when she phoned a patient in the morning to find out how they were, what she was really doing was saying, "Are you still alive?" Not "How are you?" But that's what doctors live with, which very few people understand. The pay rate for that stress is just abysmal. So I do think doctors have a very good basis for a pay claim, just on pure economic factors, but also because of the job they do, which very few people really understand.
Richard, one of the points of dispute is the measure of inflation that the BMA uses. The BMA chooses something called RPI to measure inflation, cost of living. Is that an appropriate measure to calculate inflation and cost of living, or should you use a different measure to be more accurate?
RPI stands for the Retail Price Index, and fundamentally, it is about the prices that we pay for the consumer goods that we buy. CPI is Consumer Price Index and takes into consideration a broader range of goods, but curiously excludes something which is absolutely fundamental, which is housing costs. That creates a third measure, which actually is the one that the Office for National Statistics prefers, which is CPIH. Now, CPIH, which is the one that the Office for National Statistics always refer to in their monthly bulletins, is very much closer to RPI than is CPI, because it does take into consideration this real cost of living called the cost of maintaining a household, which CPI doesn't, whereas RPI broadly does. So we have an argument here about indices. Now, you can always argue about indices and you can always come up with different measures. Let's be clear. I'm an accountant. What would you like 2 + 2 to be? The accountant's answer is, what would you like it to be? Now, so at that level, we're arguing about semantics, about numbers, but at the same time, we're talking about something which is really fundamental. Is CPI, the Consumer Price Index, a good measure of outcomes, or is the real cost of living reflected in either CPIH or in RPI a better indication, because that is what actually people feel in their pockets? And this difference is really important because it in fact explains why so many people don't believe the government's inflation figures, particularly those who are on lower pay, which in these terms, given their costs of living, many doctors are in their training periods of work. Because this is where affordability actually becomes the key word. And it's curious that this is now on the political agenda in the States, everywhere. Affordability is about, below what my income is, can I, after tax and having to meet the essential costs of living, rent, utilities, council tax, and so on, actually have any money left over to live on? And the evidence is that CPI produces a distorted view of this, and that's why RPI is relevant, because it shows that the stress on real earnings is much greater than CPI indicates. So doctors are suffering an affordability crisis, however we look at it, and CPI does not reflect that, RPI does. So the BMA is right to focus on RPI, or if they wanted to compromise, CPIH, but reject CPI, in my opinion.
Okay, just to put some more numbers on that, which is that in March 2024, we published an article that we commissioned from the Office for Health Economics, and we asked them this specific question: how much has doctors' pay dropped by, and what about the costs that they've incurred, or how much of the costs increased over the same period? And they looked at 2008 to 2023, and they calculated that on average, pay had dropped by 25% across doctors at different stages in their career, and we did break down by which stage you're at. It was all, there was a variation around that particular mean, and then they calculated also that their necessary costs, and if you want more information, look back at this article, had gone up by 54%. So that really does support what you've just said.
Yeah, that's exactly what I'm saying. You cannot now appraise a pay claim on the basis of the headline pay alone, is the point I'm making. We live in a society which is actually designed to extract people's income from them and redistribute it. That is the way in which late-era neoliberal capitalism works. We live in a society that is fundamentally structured about the extraction of rents. Now, rents are literally rents, and they're interest. And interest rates are artificially high in the UK compared to most other countries around the world in the same economic situation. But we also see rents being extracted through utilities, where, for example, electricity and gas are incredibly expensive now compared with what they were at the start of your comparison period, because Ofgem, who regulates electricity prices, has maximized the rate of return to companies and therefore penalized consumers. And we see the same with regard to water, where, of course, we now know that water bills have gone up by 25% this year and so on. My point is that the pay claim cannot take into consideration just the headline figure. It has to look at affordability. Can you actually live on this in a reasonable fashion and be able to support yourself and maybe a family? And it's not an unreasonable goal for a doctor to have a family. Why shouldn't they have one? So, God knows how you fit it into the shift system and everything else, but let's assume you can. This is something you should be able to do.
Yeah, at the very least, a reasonable standard of living. I mean, the other arguments that I've had put to me against the doctors' demands in terms of pay, number one is that if you pay doctors another 20% or however much you agree to pay them, then that will create a sort of domino effect. You'll get nurses demanding more, and then this will create a crisis in the public sector. And secondly, there's always the issue of the NHS becoming unaffordable. What's your view on those particular arguments?
Well, one thing I find very funny about those who put forward this argument that we shouldn't be paying doctors a competitive rate of pay is that the people who are probably saying that are the strongest proponents of the power of market forces. Doctors have a market power here. They can walk away if they wish. We know there are alternative career options available, not necessarily in the UK, but we do know that people are looking elsewhere and taking those options. So the market does come into play here, and yet the people who are saying that doctors should not be driven by the market system when considering what reward they should get say otherwise. We know that nurses are in a competitive market situation because, frankly, we do have shortages of nurses. Far too many young people who graduate and become nurses now are not staying in that profession as well, precisely because it is so difficult, the hours are so antisocial, and the pay is not very good. So we actually are applying a completely false standard. One is the market says that the market can't afford the NHS because the market can't afford to support government. And yet we can't have the healthcare system which actually makes the market operate. Let's be clear, which is more fundamental here, chicken or egg? I actually used the metaphor of a cappuccino once, and I called the cup the state, the black coffee, the espresso, was the government, and the frothy white milk was the private sector, with the Sunday Times colour supplement, which explained frothy things in life being the chocolate on the top. Now, the point here is that without the espresso, you haven't got a coffee at all. The state has to be there. It's absolutely fundamental. There is no business in the UK, and I've run businesses in the UK that can operate without a healthy workforce. Therefore, if you don't pay sufficient to have doctors to deliver the healthy workforce, the market will literally collapse because the people who are necessary to staff it aren't available. So the fact is that these people are looking at everything wrong. They're assuming that paying people in the public sector is a drain, and there's a total lack of productivity. Their continual argument about the NHS is totally unproductive. And yet they don't actually use the right criterion, which is that without that workforce in the NHS, they couldn't be productive at all. They couldn't literally function. So my argument is they've got all their market economics wrong.
Okay.
Bluntly, they don't understand that the market is the whole of the country, not just the little bit they operate in.
So I get that one in terms of how you value particular workers and a particular workforce. What about the other argument, though, that the NHS, I mean, as we know, there's more and more being devoted to the health service in terms of our national spend, and that it's unaffordable. I think this is what you hear constantly from politicians.
Well, I think that there's a problem here, and I discuss this quite often on my Funding the Future blog, about the fact that we actually are not looking at the right issues with regard to the NHS. Why do we have an unaffordable NHS? It's because we actually aren't tackling the problem of ultra-processed food, and therefore we have far more people requiring consultations with regard to being diabetic, with regard to being obese, with regard to having cardiovascular illnesses and all the other things that follow from literally eating too much ultra-processed food. We aren't dealing with the fact that dementia appears to be related to that as well now. We aren't dealing with the fact that society is not managing neurodivergence very well, and in fact tolerating it and rather than suppressing it. And therefore we have young people who are outside the economy and making a demand on the NHS as a result because the workplace is not willing to accept their difference as being acceptable within it. All of these are structural problems which are being dumped on the NHS to solve without the politicians ever asking the question, why are we running an economy which is actually making people sick? Because that's what it is. Or why are we running a health service which is defining people as sick when in fact they're totally normal? We just haven't adjusted the economy to accommodate them because neoliberalism wants to put us into little boxes. Remember, the whole logic of neoliberal economics is that there is homo economicus. And in fact, if you get to macroeconomics, there is assumed to be a single homogeneous human being who does all our consumption. We are all the same in macroeconomics. And the very fact is that none of us are alike, and that divergence isn't recognized as normal. The politicians aren't asking the right questions questions about why demand in the NHS is arising then. So they don't need to start with why are doctors so overworked, stressed and burned out, and why are there so many appointments being demanded. They need to start with why is our economy literally making people sick. That's the right place to start.
Yeah. One of the manifestations of that is the number of young people the proportion of young people out of work post-pandemic in the UK through ill health, which is out of sync and a very different pattern to other OECD countries where there was a rise elsewhere, but the proportions have dropped down again, whereas we have a persistent problem with young people in particular being out of work through ill health. And we know, of course, that is a bad prognostic marker for their future and for their health in the future in particular.
Yes, it is. The data at the moment is that the overall rate of unemployment at the time we're recording is officially around 5.1%, I think. But amongst that young people group, the sort of 18 to 24s or so, those who are considered to be the NEETs, it's running at around 9.5 to 10%. I mean, it's a bit hard to tell precisely, but around that figure. So double near enough the mainstream headline rate. And why is that happening? It's not because these people are totally alienated. It's not because they're useless. It is because, quite simply, the market is not providing them with jobs. And again, we have to go back and look at this question about why is the economy being structured in such a way that we aren't being willing to employ these young people. I mean, I will use an example from one of the disciplines with which I'm involved and which I know well. My last job was as a professor of accounting. It was pretty much the same as my job as professor of political economy. But I mean, that's just the way I do the two subjects. I mean, change a job title, same role. But my point is that in the pure accounting, those who are teaching literally how to do the professional skills, those people who are graduating from that discipline are having a massive problem getting jobs because the economy has decided it doesn't need accountants anymore. AI is going to do everything. And that is true of many young people now facing demands on them which are unreasonable because they are, for example, told, well, you need skills to get into this job, but I can't get any skills because I can't get a job. Well, therefore, you can't have a job. And you have no work experience. Well, no, of course I haven't. This is a starter job, but then you need to have work experience. So we have a bias towards those who can actually, first of all, literally get into the system because their parents know how to manipulate it. And that is obvious bias. And secondly, we have an absurd situation where we've created an economy which doesn't want young people because the bias is towards having skills which employers aren't willing to train people to have. Actually, one of the crises that the NHS has, because the NHS also doesn't want to train people to have the skills they need. They would rather import doctors from overseas than actually train people who are here, who've been through our medical system, who want a training job and can't get it. So we see the same problem in the medical profession. If I can be honest, it's just a variation on a theme. There is a paradox. We have young people alienated by a system which has low productivity because they could provide the high productivity that the government wants but won't be employed because they don't fit the employer's systems. We have to literally look at it and ask those deeper questions to understand why we have a healthcare crisis in the UK. It isn't simple. These people haven't opted out for a reason. They've been rejected. And that's the problem. And I'm afraid medicalisation of their condition is not helping them.
Okay. I mean, you brought up some rather big areas there, which are around neurodivergence, over-medicalisation. We haven't really got time to get into those today, but your central point around the upstream effects, the upstream interventions that can prevent ill health, let's put it this way, are the ones that aren't being prioritised in the way that they should be. That is something, of course, that we care very much about at the BMJ. But when you're in the political arena, it's hard for you to prioritise those in the same way as it is to prioritise waiting lists and things that can be done today and have an impact tomorrow that will get you re-elected. I think this is one of the central problems with our political system, in that the investments in the long-term benefits that you might accrue through prevention, etc., don't pay you a political dividend.
Oh, I think that counting the right things would pay significant political dividends. We are counting the wrong things. We are counting waiting lists, and waiting lists are important. but they aren't as important as actually caring about people. They do indicate that politicians don't care, and the change in waiting lists is used as a proxy for caring. But the truth is that actually that isn't the message that people are getting. They still get the message. If there's a few 200,000 off the waiting list, they'll say, so what? It's still incredibly long. It's still over a year. It doesn't matter. It's immaterial in accounting jargon terms. These measures are insignificant. The problem that people have is that they feel that the medical system no longer cares for them, and they don't care about the medical outcomes they're getting. People know they're not as well, and they know that politicians aren't counting that. And this is what really matters. And I think we're seeing that. I watched a program recently with Tim Spector on the television about diet. And it's staggering how poor people's diets are and how simple re-education could make a difference and reduce demand. And he did some tests and showed that. Now, I don't believe in everything that Tim Spector says, and I don't believe that every one of his prescriptions is right. But the point is, asking that question does show people that you care, but the government isn't doing that. If they actually understood that the government was on their side against the causes of ill health, and people can work this out, they do know that pollution is having an impact upon them. They do know that climate change is having an impact upon them. They do know that employers who don't care is having an impact upon them. They do know that 0 hours contracts have an impact upon them. Then people will begin to understand that healthcare is a much bigger issue. And they know, and I think the BMJ would agree with this, that actually at the end of the day, it is care and not medical interventions that finally produce positive outcomes. And care is a much bigger issue than issuing a prescription. It's a much broader and more complex issue. And that's what's missing from the algebra that the government is using here.
I think I'd certainly agree with you in the fact that the demand side is neglected, and what is prioritised is more and more interventions, more and more hospital care. And part of the reason for that is, of course, that's where the money is. Richard, and governments are thinking more about companies making profits and that then being reflected in economic growth and GDP than they are in terms of population health outcomes. Would you agree with that?
Oh, I'd entirely agree with that. In fact, let's be honest, the way in which the NHS is now managed is to increase the value of GDP. It's a growth generator in the sense that very few medical interventions are actually designed to cure anything. Most of them are about managing chronic illness and long-term maintenance of the condition. We can solve obesity. We can solve most diabetes by saying, let's stop eating ultra-processed food. That is a very simple intervention, but it is one that requires political courage. We don't have politicians who've got that political courage because taking that courageous step would reduce GDP nominally, and all they're interested in is the mechanics of growth and not well-being. So we get this desperately utilitarian approach towards the measurement of well-being through GDP, which doesn't consider distribution, doesn't consider actual well-being rather than pure counting. And it's the economist gone mad coupled to the accountant gone mad. And the result is a lack of care.
Yeah. I mean, one of the phrases you keep mentioning is neoliberal capitalism. You don't seem very enamored with it. Could you explain for a medical audience or a general audience why you're not enamored with it and what's the alternative?
Let's be clear, when I talk about neoliberal capitalism, I'm not outing myself as a Marxist, because, by the way, I'm not. I'm not even outing myself as a socialist, because I'm not sure I'm that either. I actually do believe in the power of markets, but neoliberal capitalism isn't about market power. It's about market domination and rent extraction. Market domination means that we end up with a few companies dominating the marketplace, as we see in pharma, for example, where they will actually try to extract the maximum amount of rent from the market. Now, a rent could be identified as a statin. Get somebody on a statin for 35 years and you have a continuing income stream extracted from the state to benefit the pharmaceutical company with little potential benefit to the person who actually takes it. I am advised by my doctor friends, and I've read the papers on this as well, quite a number of them, to be honest. So this is a perfect example of neoliberal capitalism. If we actually were worried about having effective markets where we needed people to participate, we wouldn't be treating with a statin. We'd be asking what are the causes of their a health condition, which the LDL is indicating to be a problem with regard to this situation, giving rise to the prescription of a statin. Now, that would be the right question, not let's follow the algorithm. But when we look at neoliberal capitalism, its job is to capture markets and control them. And that is the problem with it. So it funds all the research. It dominates the creation of the algorithms which are used for prescribing. It does, of course, provide the prescription drugs that are delivered. And it suppresses information about alternatives deliberately, which is why I say they should be talked about. And neoliberal capitalism also seeks to capture the political process, as we have seen through substantial political donations to all our major leading political parties, so that they don't question the system itself. So the perpetuation of this extraction of rents continues. Rent here is an economic term. It does not just mean payment of rent on a property. It could be excessive interest rates. It can be capture of income streams from the government. It can be high pay for executives in companies who haven't earned it. All of these are examples of rents. That's what neoliberal capitalism does. And of course, there's a cost, and that is inequality in society. And we all know from the evidence that has been produced over many years that inequality is a major driver of ill health.
Yeah. So if that's something that you're opposed to, but you're in favour of markets, what is the alternative?
Oh, I'm really old-fashioned here. I really want a mixed economy. I don't see any problem with a mixed economy. I want markets to do what they can deliver. I do not want the state to brew my beer, because I really think the outcome would be pretty dire. I don't particularly want the state to make my car, because I'm old enough to remember the Austin Allegro, and it was an appalling car. It was the first one I ever drove after my driving test. Never again. I don't want the state to do things that others can do better, but I do want to have a state that is able to deliver. And in particular, I want a state that will stand up to the power of neoliberal capitalism. In other words, what I call a courageous state, which will say, you are actually undertaking market exploitation at cost to the people of the country that we as politicians are trying to deliver. I suspect I'm talking about an overall reduction in GDP, but an increase in well-being because of better distribution. I'm clearly in favour of actually seeing redistribution from excess wealth towards those who would benefit as a consequence. That would, by the way, increase GDP, because actually reallocating wealth from the wealthiest to those with low incomes always increases GDP, because the wealthy save their money and the poorest spend it. Therefore, you will increase GDP, which is a measure of income for the state as a whole, by reallocating income to the poorest. So I do think an active state in that sense is vital. But I'm not ever going to say we do not need markets, because we do, but we need markets that are free in the sense that economists talk about them, whereby they actually are genuinely competitive. And right now we haven't got those. We've got control and not free markets.
I mean, one of the things you mentioned there was about a reduction potentially in GDP. Actually, that's one of the themes of a piece that we're publishing around now when we're looking at the climate emergency. And there's an argument in it which says that we should not be prioritizing economic growth. In fact, we might tolerate degrowth, and we should be prioritizing, the measure of prosperity should not be GDP growth, it should be health. And health is also essentially care, which is something you've mentioned before. Now, that's a logic that we also advocate for at the BMJ, that we should be prioritizing health and well-being outcomes above everything else. And it's something that's supported by evidence from WHO, and we know there are some well-being economies. But do we know that that kind of approach, A, is realistic? I mean, are we just being idealistic in calling for this? And B, are there examples of it having worked anywhere?
Is it realistic? Do you want a future, is my question. I mean, as simple as that. Actually, it probably doesn't worry me anymore. I'm 67. I'm going to be dead before the full impacts of climate change matter, but I've got sons who are in their early 20s. Am I being realistic in wanting a future for them? Unless we deal with this, they are not going to have that future, and nor are many of the people listening to this podcast going to have that future. We've known about the costs of economic growth for years. In fact, before we started recording, I showed you the first ever book that I bought on economics, which was a book called The Costs of Economic Growth, written in 1967. And I've been a Green virtually ever since 1973 when I read that book. Green in a small g, not a capital G. I'm not a member of the Green Party. I actually did co-author the original Green New Deal report, which has become, well, a slogan, a meme, if you like, around the world. Within 2 months of us publishing it in 2008, somebody called Barack Obama was using it to help him become president of the USA. In terms of transmission of an idea, pretty dramatic. The fact is that we cannot sustain growth at the level we have by consuming the world's resources at the rate we do because we are over-consuming material consumption. But there's a cost to that overconsumption, and this is the point. We only count things that are valued in money where there has been an exchange. That is a failure to count the things that matter. This doesn't allow for our emotional well-being. It doesn't matter for our intellectual well-being. It doesn't matter for our spiritual well-being, if you wish. And I don't mean that as religious. I mean it about purpose. And because we are over-consuming material items, our capacity to even consider those things is reduced, as it is by this neoliberal capitalism system, which I don't like, which actually forces us to work too many hours, as many doctors will know to their cost, and to their long-term peril even, because doctors die young because they're overworked. A fact. So what we need to do is look at how we are looking at an issue of temporality here, literally time. We are over-consuming now by borrowing from the future. That is the only way in which we can come up with a measure of GDP growth, by literally consuming what rightfully belongs to generations to come. Therefore, we have to actually reduce that level of consumption and change our focus. This is again asking about what is important, as I said, with regard to other issues we've discussed already. The issue that is important is outcome, our well-being, not the level of consumption we have on the way. And we also need to put this in the context of that wealth issue that I've already mentioned. If we look at who consumes excessively, we can go back to the work of economists over a century ago. Thorsten Veblen, a Norwegian economist working in the US by the time he wrote his thesis, which was that conspicuous consumption by the wealthy is the most destructive form of consumption there is. And now we can see that because something like 50% of all excess consumption contributing to climate change emissions comes from a tiny proportion of the world's wealthiest people, and that consumption is largely conspicuous. They're simply to say, I've got bragging rights over you. So we need to reappraise what it is that we're consuming and how and why and where and when, and that means that we need to look at the quality of life issues in a very different way. Economics, with its focus upon GDP, can't do that. GDP is a lousy measure. Robert Kennedy, before he was shot in 1968, and I remember that event happening, talked about GDP and said it measures everything in life except those things that are valuable. And that's the measure that we actually need to recall. If that was his sole legacy, and it wasn't, but he said that, it's absolutely critical we'd recall just about his last speech, because that's what he said.
Richard, thank you. Just one final question then for you. If you were, and to summarise, if you were to write a prescription for the NHS, coming from an economics background, what would it be?
Oh, I would look at it from a macro perspective, not from a micro perspective. Micro perspective is looking at waiting lists, looking at number of prescriptions, looking at numbers of people. But I'm actually asking about causes. Macroeconomics looks about how the system works. And if we add in political economy, and I was a professor of political economy, we look at how power relationships impact outcomes. And we need to do those two things. One, look at the macro level. Why is the demand for healthcare services rising so much? Why are the number of GP appointments per head of population roughly double now than what they were at the turn of the century? I think my figures are broadly right there. And why have we got this excess demand, and what is the power relationship that has delivered it? And the excess demand has come from the production of toxic substances, fundamentally. Excess alcohol consumption, excess ultra-processed food consumption, excess drug consumption even, because of course we know that actually prescription drugs do have side effects and long-term consequences. And we're seeing that particularly in the States, but it also happens here. So we need to look at all those issues and ask those questions about that. But then we need to ask, who is causing this and what are the power relationships that are delivering it? And that is because of the failure of competition policy and regulation inside the UK and worldwide markets for pharmaceuticals, where they hold governments to ransom and basically say, if you don't do what we want, we'll pull out of Cambridge or wherever it might be and we'll go somewhere else. That toxic relationship has to also be addressed, because drugs aren't the the solution to every one of our problems anyway, but we need to look at the impact of this. And if we got that right, we would solve the micro problem of waiting lists and illness, because illness is ilth, the opposite of wealth. And I love that term, ilth. Ilth is the opposite of wealth. We're either well or we're ill, according to this rather bipolar system that we're looking at in terms of economics, because that's how economics looks at things, good or bad. It's very simplistic. Well, if wealth is what they try to measure, they should begin to measure ilth, which is a recognized term, by the way. And ilth is the thing we should be tackling.
Richard, thank you very much for sharing your ideas with us today. We're very grateful to you. Thank you.
Thank you.
You can keep informed about latest developments on bmj.com. As part of our coverage, Rebecca Coombs, the BMJ's head of journalism, spoke with Dr. Jack Fletcher about the industrial action taken by resident doctors. He is the chair of the BMA Resident Doctors Committee. You can find that full interview on our YouTube channel. Thank you, and join us again next time.